Good afternoon, everyone. A very, very warm welcome to you all for this exciting debate, debating necessity of protected research time for healthcare professionals. My name is Neil Hudson-Basing. I'm the Corporate Events Manager for London South Bank University. Before we begin, I'd just like to take you through some virtual housekeeping, but I'm going to launch a poll in the background while you listen to that. So our poll is: should all healthcare professionals have protected research, education and research capacity building time within their job plan / job description? So please vote for or against, and I'm going to leave that poll up there while I take you through the virtual housekeeping. Starting with a short statement on respect and dignity. So everyone attending or speaking at an LSBU event, whether in person or virtually, should be treated with respect, dignity and courtesy. LSBU operates an environment built on equality, inclusion and acceptance. We value contributions, feedback and comments and wish to create a space for sharing, learning, celebrating and bringing communities together. LSBU does not tolerate any form of bullying, abuse, harassment or discrimination. Inappropriate behaviour will be treated seriously and acted upon, and inappropriate behaviour means that anyone will be removed from the webinar. I'm sure that won't be a problem for today. We love to see your comments on social media, and I'm going to pop the Twitter handle and the hashtag in the chat box shortly. But please keep them rational, reasonable and respectful, bearing in mind that our debaters today might only be expressing those opinions for the purpose of the debate themselves. So just bear that in mind when you're giving feedback on social media and in the chat box. We want our events to be an enjoyable, safe and warm experience for all. So thank you for adhering to those guidelines. Just to take you through Zoom functionality, you'll see that I've launched the poll. Please continue to vote in that poll for or against today's motion. The chat box is great to see people making use of that already. Please continue to share your introductions in there, share your thoughts and comments in it throughout, and we might be dropping some links in there too, including the Twitter handle and hashtag. Q&A, the Q&A box is open. Please reserve the Q&A box for your questions for our panelists for today. You pop those in there and we've got a scheduled time for Q&A later, and you can upvote on the questions you most want answered by clicking the thumbs up symbol, and that boosts it to the top of the box, and we will work our way through the most upvoted ones first. You'll also notice that there's you can enable closed captioning, and that will give you the closed captioning at the bottom of the screen. You don't have to do so, but that is enabled in the interest of inclusivity and accessibility. That's all from me. I'm in the background if you need anything. Pop me a message in the chat box. Suzanne, over to you.
Thanks very much, Neil. Shall we close the opening poll now? Great, thank you very much.
I've ended that and I'll save those results to the end.
Brilliant. So I hope you've all voted, and a very big welcome from me to today's debate. My name is Suzanne Bench and I am have a joint role across the NHS organisation and the university, Professor of Critical Care here at London South Bank University in the Institute of Health and Social Care, and as Director of Nursing for Nurse and Midwife-led Research at Guy's and St Thomas's NHS Trust. So we're here today to talk about a debate that is part of the Health Education England London region post-doctoral bridging scheme. And I am the co-lead for this scheme, along with my colleague, Professor Ben Thomas, who I'm not sure if you can see, so I'll ask him to say a very brief hello. He's on mute, but hopefully you can see him. So this is a really important scheme that's funded by Health Education London region to support people who've got a doctoral qualification to bridge that transition and to support them in the development of a postdoctoral career, particularly in view of applying for an NIHR postdoctoral award. So today, the fourth of our debates since we started running these is focusing on whether healthcare professionals should have protected research, education and capacity building time within their job plan. And we have four people who are going to be talking to this topic. Two of them are going to to be talking for the motion and 2 against. As Neil said, please do remember that people may not be representing their own personal views, but have chosen to represent a for or against motion for the purpose of the debate. So first of all, we have Jen Sutton. Jen is a research occupational therapist based at South London and Maudsley Mental Health Trust and King's College London. And also, so she's going to be talking for the motion, and also talking for the motion we have Dr. Edward Baker, and he's a consultant nurse in the emergency department at King's College Hospital Foundation Trust. Then against the motion, we have 2 people. We first of all have Dr. Joe Texera, who's the lead nurse for research at the Royal National Orthopaedic Hospital. And also against the motion, we have Dr. Danny Bear, who is a consultant dietitian at Guy's and St Thomas's NHS Trust. So each of them are going to have 6 minutes to talk, and we are going to go in an alternate fashion, so for against and for and against. So with that in mind, I'm going to now hand over to our first speaker. Once they've all spoken, we will then open it up to Q&A. So if we can hand over to Dr. Jen Sutton, who's going to give us the first 6 minutes on why this should be in place. Thank you, Jen.
Thank you so much, Suzanne. So yes, today I'm going to be putting forward an argument for why there should be no doubt in your mind why all healthcare professionals should have protected research education and research capacity building time within their job plan. Next slide, please. So what do we mean by this? Because these are very broad terms. Research education, well, that can encompass things like training and research skills. That could be applying research or critically appraising research. It can include keeping up to date with research in your area of specialism. And it can also include sharing of research through things like journal clubs. Research capacity building, well, it's literally just that. It's building the capacity for research. So to lead research, to facilitate research, and to translate research into practice. This can be at an organizational level, it could be at a team level, and it could be at an individual level. And when we're thinking about individual skills that are required, this can broadly be set out into 3 areas. So foundational skills in using research, so that's how to source relevant research, that's relevant to your area of practice, how to critique it, and how to use it to inform clinical practice. Participating in research, or I think a better term is kind of facilitating research. This is everything from having an awareness of what research is happening in your area so that you can support service users and patients to engage with that, to actually being involved in a study as a study researcher. And then leading research, we're looking at being at the forefront of developing and leading research studies. Next slide, please. So why is this important? Well, we know that research and innovation are key to improving patient outcomes. They're important for preventative measures, for diagnostics, treatment and recovery pathways. And this is really clearly set out in the NHS long-term plan. The NHS long-term plan also draws on data that we have to show that there are lower mortality rates in research active hospitals compared to non-research active hospitals. And this benefit isn't just linked to people who've engaged in research, that's across the board for anyone who's accessing those services. So in direct response to this, Health Education England, they, as part of their allied health professionals research and innovation strategy, they said that by implication, all healthcare staff are accountable to have the knowledge, skills and confidence to apply research within their own scope of practice. So to me, this really highlights the importance of research education and those foundational skills and research capacity building. Next slide, please. So to go a step further, I want to talk about research as a pillar of evidence-based practice. So we know that research is the backbone of evidence-based practice, and evidence-based practice is included in every single healthcare professional's code of conduct. So if you're looking at the Nursing and Midwifery Council, the Chartered Society of Physiotherapy, my own World College of Occupational Therapy, research and evidence-based practice, it's a core duty. So to give some examples from the Royal College of OT, it talks about how we need, as OTs, we have a duty to reflect on the value of research and the importance as a foundation for our professional evidence base. We have a duty to access it, understand it, and critically evaluate it and apply in practice. And that's, in order to demonstrate effectiveness of interventions and services. So I think it's really clear that the research education and those foundational skills in research capacity building is quite literally part of our professional code of conduct. So it's an essential part of our job role. Sorry, next slide, please. To take this a step further and to think about it in terms of delivering research and in terms of leading research, well, we need it to be able to develop the evidence base. We need engagement from all clinical staff for research to actually be conducted in a clinical setting. Otherwise we're not going to be able to facilitate research in healthcare settings. We know that research is led by healthcare professionals with a working knowledge of the setting, with a working knowledge of the needs and the issues in that service. Well, that kind of research has much more real world impact. It's much more easily translated into practice. So that's really important. We need to be able to develop the evidence base so that we can advance knowledge of different professions, evidence their effectiveness and their cost effectiveness, and evidence models of service delivery. And currently, certainly in current day and ages, we need to be able to evidence how well we're doing and why we're of value. And it's also important for targeted research needed to inform strategic planning and policy making. So if we have research capacity building built into job plans, we'll better be able to facilitate and lead research, I think. Next slide, please. So for me, everything that I spoke about today is really succinctly set out in Saving and Improving Lives, the Future of UK Clinical Research Delivery. There's a really lovely quote that I wanted to draw on, which it talks about how clinical research is really valued by healthcare professionals as a driver for improving quality of care, but actually that staff aren't always able to deliver research as part of their day-to-day activities, and that research can quite often be seen as someone else's business. It's seen as the business of clinical academics, it's seen as the business of research team, but not necessarily as of an individual clinician. But it sets out that this has to change. So whether it's helping to deliver a clinical trial, supporting patients and service users to access the latest research, or to adapt current practices in line with new findings, delivering research across the NHS is everybody's business. And that's my kind of key take-home message, I think. So, what's the solution to this? How can we ensure that it is everybody's business? Next slide, please. We need to ensure that all healthcare professionals have protected research education and research capacity building time within their job plan. This will signal the importance of research activity, and it really speaks to the culture of an organisation. It provides a mandate, space and time to be research active. And whilst we're not saying that everybody's going to be a clinical academic, there may be some clinicians out there with an interest in research and an idea to improve patient care, and having this in their job plan will allow them the scope to become research leaders of the future. So for me, it's important across all levels. Thank you for your time.
Now I will talk about the reasons to be against this motion, and keep in mind two key words for me is all and job description, and keep it simple. Next slide, please. So keep in mind a very simple idea. What is the research cycle? Imagine someone have an idea, develop a design, implement it, evaluate it, and have the outcomes. I see research process in two big parts. One is the active production of knowledge. Another one is the evidence base or implemented these results in practice. And for me, this knowledge about how to implement evidence in practice should be explained and taught in the universities. We should not burn the healthcare professional, the healthcare institution with the burn of teach their professionals. And by the way, this should be part of the core of their education and undergraduate courses, because all of us need to practice using the best evidence. So next slide, please. So when we can look for the nurse standards and registered nurses, we all need to use the best evidence in practice. So we cannot get the skills after get the job. So should not be in the job description, should be part of our core of skills to practice. So for me, research education is part of this motion, should be part of the professionals' education and not be part of the job role description. Next slide, please, Neil. So regarding the second part of this motion, is the previous one, please. So next one, sorry. Next one and the next one. So regarding the core of the profession, we need to look to our professions itself. So if you look to the clinical academic roles, definitely I believe that the clinical academic have essential role in our job, in our institutions. Without any doubts that we know the benefits of clinical academics in produce new knowledge implementation, and they make difference not only in the care provided, but in guidelines and policies as well. However, the discussion today is for all professionals with clinical academics, and why we should be different, for instance, from our colleagues, physicians, that only 5% of them have clinical academic roles, and we know they produce enough knowledge to be implemented in practice. But you can agree with me, say, Joe, but we are new in the job, we are more motivated. Next slide, please. But the studies prove, even though staff very well motivated, as the case of this study, that clinical PhD students, they were very aware of their role and they're very engaged. Only 50% then were aiming to be clinical academic in the future. Next slide, please. So I will like you to do exercise with me. Imagine we are living in an ideal care system with no sort of staff, no strikes, no pandemics, that clinical academic roles have all the description and all the time in the world and progression in their career. My question for you is, are we all have personality to be researchers? Because the image you see is all the skills are required for be a clinical academic as independent in the field. Do you think all of us have this personality or are willing or have the motivation to do it? Next slide, please. So I think the key factor is how we need to think about what are the factors that influence professionals in their choices. And one of them is motivation. So again, are we all motivated to be researchers in the field? Because next slide, please. If you are not motivated, we know even though with ability, we go decrease our performance. And if we decrease our performance, we'll do less, we do a worse work, we feel less enjoyable, and probably they will have consequences like sick leave, conflicts, increase the turnover in the jobs, and worse, I think will produce a bad reputation for clinical academics, what we should avoid at all costs. So next slide, please. So what I would like to finalize, next slide, please. So what I would like to tell you all is, I believe it that we should have protected time in our jobs, but not for all healthcare professionals. We should have the option that to choose be it or not clinical academics, and that the research education should start in universities and not in the job description. These are the reasons why I'm against this motion. Thank you.
Lovely. So I'm going to be on. Hi, my name's Ed Baker. I'm a consultant nurse for emergency care at King's College Hospital and a postdoctoral researcher in major trauma. And I'm going to be presenting an argument for this motion. Next slide, please. So when considering the significance of the debate, it was important for me to have an understanding of the current levels of research activity amongst nurses in the UK. But it's really challenging to find specific data. In this recent survey of UK neonatal nurses, it was estimated that 0.2% of the neonatal nursing workforce was doctorally trained, while 0.02% of the workforce was active in both clinical and academic settings. Although this can't be generalised to the wider workforce, it is reasonable to assume that this would not be dissimilar to other areas of nursing. In this same study, they identified some of the key barriers to involvement in research, and these included a lack of time, limited support, and a lack of role models. Next slide, please. So looking at the Chief Nursing Officer's strategic plan for research, which was published in 2021, the need for and importance of developing nurse-led research was highlighted. That most nurses don't see research as part of their complex and challenging role. If we want to change this narrative, we need to develop the workforce differently in the future by planting the seed of interest early in every clinician's career to unlock potential, by ensuring that research education is available to all, suitable to all aspects of clinical education, by ensuring that the opportunity to be involved in research is normalised, no matter how big or little that contribution is. And we need to ensure that these opportunities are built into job descriptions to show that organisations are committed to these changes. Next slide, please. And this is echoed in the literature, where there is evidence about the impact of research active clinicians and research active organisations. So I've selected a few pieces of evidence here, and these kind of demonstrate the positive impact research activity can have on patient experience and patient outcomes. Next slide. But the problem is likely to impact on more than just our current health and social care workforce. This recent article from The Scotsman highlights that healthcare professionals in training see research activity and knowledge as separate from their clinical practice. This is largely based on the ever-growing theory-practice gap and the lack of consistent, clear clinical academic role models within the healthcare setting, adding momentum to those opinions conveyed in the Chief Nursing Officer's research strategy. If we don't provide clear pathways and role models for research active clinicians during the earliest stages of their career, expect them to develop an interest in clinical academic roles and grow the future research leaders in our clinical practice. Next slide, please. So by pulling these things together, we can show that research activity within the non-medical workforce is essential to which are meaningful and relevant to patients and maximise the translation of evidence effectively into clinical practice, to optimise these patient outcomes and maximise the patient experience, to ensure that clinical care is provided and is acceptable and impactful for patients, and to ensure that the care provided is efficient and effective in the risk of research wastage. Next slide, please. So I'd like to kind of present a mini case study. And through a collaborative approach, Imperial Healthcare NHS Trust and their Academic Health Science Centre has developed a core programme of research education and research capacity within their non-medical workforce. An example of the education provided through this programme is the Start Out in Research course, and this aims to provide an increasing diverse group of healthcare professionals with the skills and knowledge required to grow their involvement in research. Feedback from one nurse participant reported that after completing, inspired to apply for a research nurse job within the trust, which they were successful at interview and now have a role in research delivery. More generally, there is an overriding commitment to education which is accessible, compelling and embedded in practice, support of the organisation for clinical academic career culture which is open, inclusive and extends across all clinical areas, and role models who cross the divide from academic and clinical practice. For me, this demonstrates the need for a broad and inclusive strategy for research education, which will enable us to have a future workforce of upskilled research active healthcare professionally. This will lead to greater diversity in the research leaders of the future. Next slide, please. So, stealing a quotation from Florence Nightingale here, I believe we must sow the research seed wide to enable us to reap the benefits in the future, because who knows how fast the seed can grow. It's only through sparking the interest early in people's career that we can widen participation and ensure that every professional has the opportunity to meet their potential. This isn't to say that all professionals will become research leaders in the future, but it will allow the possibility to the largest number of people possible. It's to be done through an organisational commitment by recognising this time in professionals' job plans or job descriptions. Thank you very much for your time.
Thank you to all of the previous speakers today, and particularly to Dr. Baker and Dr. Sutton for really providing a lot of evidence that actually supports my motion, which is against the fact that research education and research capacity building should be included in the job descriptions of all healthcare professionals. So there is no doubt that research in the healthcare setting is important, and this has already been nicely highlighted by the previous speakers. We know that the benefits to patients and staff and NHS trusts overall are certainly evident. The benefits are also highlighted in several national research strategies for different healthcare professions, including nursing and allied health professions, or AHPs. Since Dr. Teixeira has already focused on the nursing side, I will focus my argument specifically to AHPs, but it's certainly relevant to all healthcare professions that work in the NHS. The AHP research in innovation strategy includes ambitious aims, one of which is that research, innovation, and quality improvement be embedded into job descriptions and routine practice across all stages of the allied health workforce. Despite these clear and ambitious statements and aims and the arguments put forward by the previous speakers, I am going to argue against the motion that research should be included in the job plans of all healthcare professionals for two reasons. First, not everyone wants to have a career in research. And this is not a bad thing, as diversity is important in the NHS, and that includes diversity in careers and also diversity in thought. And second, the NHS is facing a catastrophic staffing and financial crisis. And I argue that money is best spent on developing those who wish to pursue a career in research, rather than focusing on including this for everyone, which, let's face it, is really expensive. I want to take you back to the definitions of research involvement, which were briefly described and explained by Dr. Sutton earlier on. Research involvement can broadly be broken down into 4 stages, and there are several different versions of this framework, but I've chosen this particular one. Level 1 at the bottom is being the understanding, interpreting, and application of evidence-based practice. And this goes right up the top to level 4, which is research leadership and those who have a clinical academic role. For the purpose of my argument, I'm not really interested in level 1. As we've already heard, we all do this. It's part of our professional practice. We follow guidelines and policies that are based on evidence, and we might even be involved in developing these in our own clinical areas by doing a literature search and utilizing the available research. We all have study leave and CPD time to be able to continue our learning, which is included in this level 1. And it's often, or most usually, embedded into our job plans already, either formally or informally. I am going to focus on, and I'm most interested in, the levels 2 to 4, which are really the areas that are often seen as an out-of-reach luxury and get put to the side when clinical work is busy. They do require funding, and they do certainly require time within a job plan to be able to participate in research leadership and collaboration to any purposeful degree. However, without the leadership at the top levels of this research framework, the facilitation and supervision of skills development at the lower levels does not occur. And this is exactly what Dr. Baker explained to us earlier. This has been shown in multiple studies exploring the barriers and facilitators to research capacity and culture across a variety of healthcare professions, where barriers are frequently cited as the lack of support and recognition of the importance of research from senior management, lack of role models, and lack of clinical academic pathways. This then influences the low knowledge and confidence of staff at those lower levels of the pyramid to be able to undertake research activities. Further, the perception, or realistically the reality, that clinical commitments take precedence over research activities in an already stretched service further add to this list of barriers. Facilitators and motivators support that research capacity and culture is not possible without research leadership roles across facilitators and motivators are also support that research capacity and culture is not possible without these research leadership roles, as these facilitators and motivators are expressed as having strong role models, mentors, and experienced research staff at the top of that pyramid. To further support my argument that money is best spent on developing sustainable careers at the top levels of research, the AHP Research and Innovation Strategy acknowledges this by specifically incorporating an objective to see more AHP educators being more research active. Lastly, all of the case study exemplars for building research capacity within different areas of the NHS for AHPs are focused on how research leadership roles have developed this for the rest of the staff at those lower levels of research. This continues to highlight that establishing research into job plans and job descriptions is not possible without those leadership positions. And in fact, Dr. Baker also showed a case study that did explain how those research leadership roles were able to develop the researchers at the lower levels of engagement. What this all points to is the need for talent management and targeted career progression. We need to do more to nurture the next generation of research leaders across all healthcare professions by more systematically identifying and developing and supporting those with the capability and the ambition to reach the most senior levels of the service. We should do this by focusing on moving those from level 3 to 4 and then 2 to 3 and so on. This will mean that there is strong leadership to then go back down to the bottom of the pyramid to provide the training, education and support to those who choose research as a career path. I will conclude my argument against the motion that research should be included in the job plans of all healthcare professionals with this quote that says, "Someone asked me what I'm going to do when I make it to the top, and I said reach back down to help the others up." We should focus the precious resources of the NHS to support and develop those who wish to have a career in research, to get to the leadership positions, to then help the others who wish to do the same. Thank you.
Thank you very much to all of our speakers, both those for and against. I hope you agree that there was very strong arguments, and I certainly felt myself swaying from one side to the other as we went through. I can see that there are some questions in the Q&A box already, but please do continue to put your questions into the Q&A box. And we've got about 18 minutes now actually to have a conversation and to probe a little bit further with our speakers. So I'm going to start off with a question that has been voted at the top that was put forward by Winston Morgan, which is there a confusion here between research, generating new knowledge and scholarly activity, awareness of research developments to improve practice? Everyone should be enabled to participate in scholarly activity, whilst perhaps not everybody can or should participate in research. I think there's certainly some things there that are coming out from what we've just heard from Dr. Baer. So would anybody like to respond to that in the first place?
I can start, Susan, I can start. So I really agree that all of us need to be aware of the importance of research and how to use it in practice. This is my main argument. Of course, everyone can help students, but when we talk about support students, special and graduate, it's more about how they can use the evidence in practice. It's not produce new knowledge. And I think this is a huge confusion. The other thing is, not all of us feel they should be researchers, clinical academics, and produce new knowledge. It's like be midwifery, not all feel the motivation, or they don't want it at all. They don't think they have the skills to do it. And it's fine. And the problem is when we push everyone to do exactly the same thing, and the person is not motivated or don't want it or don't have the skills, we will create a huge problem in the institutions. This is my feeling. I don't know what my colleagues want to say.
Thank you, Jo. Yeah, Ed.
You know, just to jump in, I guess my argument against that is unless we offer opportunities to a wider group of people, you know, growing that in as many people who we possibly can. I think you know, the targeted approach is very good, but then that has implications in relation to inclusivity and, you know, potentially, you know, equality that we need to think about. And I guess that argument isn't about everyone becoming a researcher in the long term, but it's about how we give people a even playing field in relation to opportunities to grow that, and therefore have an equal potential to become that within their career.
Excellent, thank you. In view of time, I'm going to move on to the next question, if that's okay. That comes from Efwa Hagen. So Efwa says, with shortages of staff and the lack of time on the shop floor, how can we propose that we all become clinical academics? I think there's a bit of an overlap in this question, but I suppose I would also build on that and say, you know, also how can we perhaps persuade some of those managers with their budgets that we should give more of the clinical staff on the shop floor time, formal time within their job descriptions to do this? So who would like to respond to that?
Can I start? Okay, so
Please do.
for me, I think this is actually part of the big problem. So I don't think, I'm certainly not proposing that everyone become a clinical academic, and I don't think that incorporating kind of research education and research capacity building into job plans means that everyone's going to be a clinical academic. What it does mean is that everyone, it kind of focuses the need to be aware of current research and how you apply it in your practice, and to be aware of research studies that are perhaps happening in your area and how you can support somebody to engage with those studies. And I've seen that in kind of band 4, band 5 job plans. I work for South London and Maudsley. We have research in all of our job plans, and it really does speak to the kind of the mandate of our trust. And yeah, I don't think we're necessarily, I think there's a bit of confusion there. I'm not suggesting that everyone should become a clinical academic, but I'm suggesting that some form of research capacity building should be included in everybody's job plan. Everybody should be able to point someone in the right direction of research that's happening in their area, and everybody should be able to you know, read research and apply it to their job role.
Danny, would you agree with that?
Yeah, so I was also going to say we do need to be a little careful with terminology, because our argument was not that everyone should become a clinical academic. It was that research capacity building and education time should be included in job descriptions. So I don't think anyone is proposing that everyone should be a clinical academic, because, you know, we know, as I said, that diversity in the NHS within careers is incredibly important. This is where I think the pyramid, the framework that I showed for research engagement, is really, really helpful to distinguish between the different levels of research, because that level 1, which is what Jen is describing, so everyone should be able to implement research and know what's out there. We all do that anyway. So whether or not that's you are given time within your job plan to do that, it is part of your professional practice. And, you know, to be compliant with HCPC and perhaps your other regulatory bodies, you have to show that you can do that, and you have to be doing that. It's more, I think, for me, the collaboration and the leadership in research and the thinking about your own research trials that doesn't get put into job plans. And that, for me, is where we need to focus on those people who want to have a career. And the NHS is apparently all for clinical academic careers, but they are still few and far between. I think the latest data I saw was 0.8% of AHPs are in a clinical academic post at the moment. So, you know, management at the top need to be changing that.
Thanks, thank you. Okay, we're going to go to a question from Jordana now. Sorry, it's just flicked up from my screen. So Jordana says, the discussion today seems to highlight the lack of funding for clinical staff rather than the importance of including research time into clinical practice. So the question is, could funding be provided by research organisations to support this, the UKRI and MRC, for example? Who would like to take that question?
I can start off. I mean, I guess it's almost a different question to what we've been debating today. You know, the if and what is different to the how, I guess. But that would be one route we could fund it. There are lots of different ways. I personally think that if we change the way we teach research and evidence-based practice right at the start of people's career and make it more applied and more relevant to people's practice right at the start whilst they're training, that then people people will have the ability to then undertake that level 1 work, because I think actually what we see in practice is a variability in people's ability to appraise evidence and implement it into their clinical practice. You know, some clinicians are very good at it, but there are also other groups of clinicians that maybe are less, have less experience of doing that. And I think that maybe starting very early in the career is key to actually, getting a foundation of knowledge and skill in relation to how that practice is established in people's longer term career plans.
Great, thank you. So I suppose just sort of building on that from the other side of the teams, do we think we should be putting more pressure on some of these external bodies then to provide this funding?
I can answer this question, Susan. I think the main point of this, and is linking with Daniel arguments before, is not the external funders. We have some jobs in the job description, they have research time allocated. The problem is, again, is the middle level of management. So who designed these studies probably people don't have in their undergraduate courses nothing about research. They know now to attract people for some posts, they need to put this in the job description, a kind of couple of lines about the job and relate with research. But in the end of the day, in practice, these colleagues feel frustrated because they don't develop nothing in research as active researchers. So the money is around, they are able to have jobs with this kind of description, but at the end of the day, they don't do the role, and especially for 2 main reasons. One, no support of the managers. And second, they don't have leaders in research in their institutions to support them go through this pathway. So it's not about external funders, it's about the best use of the post inside of the institution. Special line managers understand what is being a clinical academic and not confused, for instance, to be a research nurse. I talk about my field. It's not collect data for others, it's design their own projects. They have their own career in the field.
Yeah, a really important distinction, I would say, Jo, isn't it? That and traditionally, if you mention the word nursing and research, people often think about research delivery nurses. And whilst those are important, we need to think about both sides of that. I'm going to come to a question from Adam. I think this is a very topical question. So Adam says that there's often an expectation for staff to do a lot of admin time in their work in their own time, and often this admin time incorporates actually anything related to research as well. So if you want to do a review of the literature for a policy or something like that. Adam says, is this a reasonable expectation anymore, given that actually the view that work-life balance is important in current and future graduates? Who would like to take that question? Danny's got a hand up immediately, so we'll go to you.
Thank you. I can start because I do have some thoughts on this. So my view is, and certainly the experience that I've had, is not that that is an expectation, but that it is simply a requirement, a personal requirement based on the fact that your clinical workload is so high that you cannot fit that within your normal job role. So I've never had a manager who has ever expected me to do that work outside of my normal clinical work hours. And I certainly, as a manager, do not expect my own staff to do that. But what I will say, that the only way that I have personally been able to progress in my own research career is by doing additional hours. That is just a fact. And regardless of whether I think it's right, it is a fact. So I don't think it should be an expectation that we do additional work outside of hours. But I do think the reality is that if you want to progress in your research career, there is a lot of work that needs to be done out of hours. And I don't know how to get around that, because 37.5 hours a week just seems, even if you're a full-time researcher, still does not seem to be enough.
And I suppose there is a potential argument that actually you get something out of this as an individual as well. So obviously you hope it would benefit the organisation, but there's a personal gain in terms of your own CV and career development.
Absolutely.
Perhaps Ed's put his hand up there, so he's going to rebuke that perhaps, but go ahead.
I think just just to add to it, I think it lends itself back to the original question about job descriptions and job plans. So people that are in a position where they can negotiate their job plan with their line manager. I think I've started to do this effectively in my new job at KCH, is how you can then negotiate that research time into that job plan, so you don't necessarily have to do all of this additional stuff outside of your working hours, because actually you've got it quite clearly documented and proved that you can take this amount of time per week to undertake this type of activity, which isn't part of your clinical work. So I think if you go back to the job planning process and start to build some of those activities into that job plan, then you can reduce the amount of time you potentially have to do.
Thank you, Ed. And I think just sort of building on that in terms of your role and Danny's as well as consultant level practitioners, there is of course the requirement to fulfill the 4 pillars of advanced practice, aren't there? So you know, that's an argument for protected time to deliver on that pillar as well as the other 3. I want to come to a question now by Patrick Duff. He says, considering the stressful, to say the least, these are his words, few years healthcare professionals have had, coupled with the ever-increasing pressures, do you think there's enough energy, appetite and enthusiasm in the healthcare professional population for research and academic time? So this sort of talks a little bit to what Joe was saying earlier. So I don't know whether you want to come in first, Joe, actually, just because you did talk a little bit about motivation, didn't you?
Yes, I quite like it. I'm the nurse research lead, and my role is actually motivate people. And to be sincere, I think after these very difficult times, people come to me to know more about research. They think like be a little fresh air. This is the word. Again, will not be all the colleagues. So, and about to motivate people, we need to find leaders, to find potential strategies, to give them what is the overview, be clinical academic. For instance, in our institution, we have the nurse internship, and now with the AHPs as well, what is amazing, to give the flavor, what is be this role and help them in the future to progress. So it's again about leadership and support these colleagues, because people are willing to do more in the research field. This is the point. Not all, but people want to do it, but they need support. They need someone to guide them and say, this is the path, this is where you want through, where you want to go further, and see what their expectations. So this is about leadership and support them. And to be sincere, I'm quite happy what's happening in our institution, but I'm aware as well, and other ones, and maybe bigger, have no support at all, and people contact us in our institution, can you help us? So this means people are willing across other institutions as well. The point is about leadership, Susan, is my point of view on this, and make understand the difference between what is be researcher or be research nurse. This is the key as well.
Thank you, Joe. Jen, I don't know if you've got anything to add to that, or Ed.
I completely agree with everything that Joe was saying, and I think, but we do need, it's just having that kind of protected time to be able to think about that. And I'd say from a leadership point of view, it's really important, because you need the kind of clinical academic leadership to then support other people. I saw a different question a bit further along around kind of engaging people without being a clinical academic, and really you need, certainly in my role, I've been able to kind of recruit clinicians as researchers and train them up, and I think it's really, really important. So yeah, it's that leadership to make sure that all levels are completed.
Yeah, thank you. And I do know Nick Cross has brought that up actually around his research and inclusive part of inclusive leadership and compassionate leadership strategy. So I think hopefully that talks to that question as well. We've got 1 minute of question time left. I'm going to ask one really final quick question, which is, what would be the alternative option to not including research capacity in people's job plans and descriptions? So this person says, as a division, we're involved in national portfolio studies, but many people don't have protected time to take part, even though they've got an interest. So is there an alternative way to achieve this? Joe, I think you have your hand up. We'll just take the last word to you, Joe.
So it's a very quickly example. At the moment, it's few jobs with this option. So I think it's a role of the leaders of the institution to pick up the key people in their departments and see if they are interested in this field or not. And again, pick up what Edward just said to us, is go through their appraisal, for instance, and say, I can see you are very interested in this area. Can we build a new appraisal? What are your goals in the next 2 or 3 years, and guide them? I think we don't need properly be right down at the moment, and help with these examples build a future job plans according what is going on in the institution. So again, it's about the middle ladder of management, pick up these people who are interested.
Thank you. I'm going to stop us there because it is 10:02 and we're on time. And I'm just going to give each of our speakers now the opportunity to summarise their key points. I'm going to give them 1 minute each. So we're going to start with Jen and then go on to Ed. So we have both fors and then both against. So Jen, start with you. You're on mute, Jen.
So sorry about that. That's embarrassing, technical difficulties. So yeah, I very much agree with the points made by Joe and Danny about the importance of research leadership, and not every healthcare professional wishes to be a clinical academic. I totally agree with that. However, research capacity building encompasses so much more than that. It's not just about leading and facilitating research. It's also about being able to engage with research and apply research, and ensuring that that evidence, like that research, isn't translated into evidence-based practice. Research really is everybody's business, and the only way we're going to be able to build the research capacity and capabilities of our organizations is incorporating it into job plans, and have it, you know, it doesn't have to be that somebody is a research leader. It could just be as simple in someone's job plan as having awareness of up-to-date research happening in your area, and being able to point people in the right direction of research that's happening. So I feel like, you know, if you have it in the job plan, it signals it's everyone's business, and it's really, really important.
Great, thank you very much, Jen. Ed, your 1 minute.
Lovely, perfect. And I agree with absolutely everything that Jen said previously. And I think for me, it's just to reiterate what I might have said before about the, you know, I think it's wide in our search for the researchers and research leaders of the future. And I think that that can only be done effectively, you know, by planting that seed of interest early in a diverse group of clinicians' careers to unlock the maximum amount of potential, by ensuring that research available, you know, everyone that wants it, suitable, furthermore integrated into all aspects of clinical education, by ensuring that the opportunity to be involved in research is normalised, you know, within people's day-to-day clinical practice, no matter whether that's, you know, them running a or them identifying a patient who could be eligible to participate in someone's study. I think that's key, and also ensure that these opportunities are therefore built into job descriptions, so we recognise that activity, and it allows organisations to commit to changing things in the future.
Thank you very much. And now the final word from the against team. So Joe, let's come to you first. 1 minute.
So without doubt, research is everyone's business. I'm not doubt of that. But what we are discussing today is a kind of generalization to everyone of this capacity building time in their job description. And I'm quite cautious about generalization, because we can create a risk of creating poor reputation for clinical academic staff, and job dissatisfaction, decrease the rotation of staff. So we need to be cautious the way we approach this need of research awareness. Other thing is the active role of produce new knowledge. So I think imposition should not be a strategy to build a career of excellence. And we need to think as well, we need to support our colleagues they feel motivated to do in their career. So this is the reasons I am against the motion.
Thank you, Jo. And the final word goes to Danny.
Thank you. So from my point of view, as I mentioned, the NHS is facing a catastrophic crisis in terms of staffing and in terms of finance, and including research in the job plans of all healthcare professionals just isn't sustainable when clinical care is clearly the current priority. But remember, when I'm talking about research, I'm not talking about that basic level 1 of implementing evidence-based practice that Jen has referred to, because I already believe that is in the job plans of what we do as healthcare professionals. But I believe that instead resources should be focused on developing a talent management program that targets those who wish to have a career in research and supports them to reach that top levels of the research leadership pyramid, which enables the support, knowledge and skills to be focused towards more junior researchers for this process to continue. And it doesn't take away from the diversity in careers and thought that are required within the NHS, and also does still highlight the importance of research to us in providing clinical care to our patients.
Thank you very much all. Fantastic talks from all of you. Easily could be persuaded either way, but I'm going to hand over now to Neil, who's going to open the final poll to see if you've persuaded people's opinions.
I am trying to launch said poll, except it's saying failing to launch, so bear with me.
Oh no.
There we go, that's
go.
launched, there we go. So final poll, so the same as last time, should all healthcare professionals have protected research education and research capacity building time within their job plan / job description? So we'll give that a moment to vote. People votes are coming through very fast, and we will refer back to the results from our opening poll. We're about 75% of you have voted, so keep those coming through. Keep your comments coming through as well. It's been brilliant to see those. We do refer back to the chat box, all the comments in there, all the questions, those are all collated, and they can inform future discussions, activities and events. So we are almost at, we're at 81%, so I'm just going to give you another moment. Just to say, please continue to share your thoughts and comments in the chat box and on Twitter, help keep the conversation going. This session has been recorded. I popped in the link to the previous debates there. They're all very well watched on YouTube. This will be uploaded there too, and do share it with anyone you feel might be interested in watching a later date. And feel free to dip back into it. So we're 86%. We'll just give it another moment. As someone said, very difficult to decide. A blend would be good. Well done to all involved. Lots of great comments coming through. Great debate and difficult to decide. Lots of really valid considerations. Helpful to discuss and hear your advice, thoughts. Thank you. When is the next one? Question just come through.
Well, the next one will be as part of our next scheme, which we're just interviewing the candidates for in the next couple of weeks. So this is an annual scheme, and we have 2 debates running each year for the scheme. So it will be next year.
So lots of great questions, but I'm going to end the poll there. So I'm going to share the results. So you should be able to see 76% are for and 24% against. That means that, so the 14, everyone is in favour. However, when we started, 96% were for and 4% were against. Wow. So there has been a sway. So congratulations, everyone. Suzanne, over to you for closing words.
Well, that is amazing. So so well done to the team that won the debate, if we can call it winning. But thank you again to all of you for your contributions. I think the comments in the chat box really reflect how useful the debate was, and hopefully has really made everybody think about this. It is incredibly difficult to think about how we can embed research into clinical practice at a time when there are so many other priorities, and really hope that this has helped you to think about how that might be taken forward. So thank you again to all of our speakers. Thank you for joining us, and we'll say goodbye on that note. Thank you.
Thanks, everyone.